Hello, good afternoon, or good evening.
القصة باينة ولا لأ؟ بس عشان أنا خارج من العمليات شعري مبطط طالع. القصة بس بيصدروا تركيا. Hello everyone. This is the second session of the conjoint meeting with Iwad Hospital in Egypt and Epico pharmaceutical company leading in the field. This is the Phacoemulsification session part 2. I would like to welcome Dr. Ogundipe from Nigeria, the head of the Ophthalmological Society of Nigeria, and Dr. Oyelai, who are the moderators and the co-chairs of this session with me. I would like also to welcome Dr. Hisham Gharib, who is a consultant ophthalmologist working at Iwad Hospital and consultant at Ain Shams University in Egypt. And he will be starting by the session on viscoelastics, and then we'll continue about phaco-dynamics, and then moving on to difficult and complicated cases as well. Dr. Hisham.
Thank you, dear Dr. Ihab. Welcome, Dr. Ogedibi and Dr. Oilai. Welcome all our colleagues. We will start today by our tools that will be helping us in phacoemulsification techniques. Our tools, our hands beside our body, will be our surgical instruments, the ophthalmic viscoelastic devices, and the surgical machines. I'll start by the surgical instruments. You should know your surgical instrument and what suits your technique so that you enjoy easy surgery. Anyone may be formed of stainless steel or titanium. While the titanium is lightweighted with good tensile strength, they are durable because of repeated autoclaving. They are corrosive resistant, non-ferrous, and they are non-reflective. Starting by holding the eyes together. We should use speculum. The wired speculum has the advantage of less intraocular pressure rise during the surgery, while the screwed designs aid in opening the lids with better adjustable exposure. The open blades on the left side provide the space for instruments and the phaco probe to gain access into the eye, while on the other hand, the solid blade specula sequestrate the eyelids and lashes from the field. There are many designs of the specula, and you should pick your preferred one. Second, how would we fixate the globe, especially while inserting the MVRs and the keratomes to make the incisions? We may use a fixation ring that comes in semicircle or complete circle, but be aware of these teeth that may cause trauma. Fixation forceps, as the Hudson or the Colibri fixation forceps, may be another alternative. As we go inside the eye, the capsulorhexis forceps is one of the important instruments that is to be with you. Best capsulorhexis forceps should have fine arms, delicate blades, firm grip, and good control. Sharp tip may be present to open the encapsulated the capsule and to elevate the flap. There are curved blades for tunnel incisions, crisscross blades to enter through very small incisions, 1.8 millimeters, and microaxial forceps that can enter through the paracentesis. Again, you should use what suits your technique. Management of the nucleus. We can manage the nucleus by cracking it in one of two different types of chopping, the horizontal or the vertical one. With the horizontal chopping on the left side, cracking of the nucleus is done through the equator of the nucleus, while with the vertical choppers, we use to crack the nucleus by impaling the sharp-tipped chopper through the nucleus and cracking it into pieces, as in the left side, as in the right side. So the horizontal chopper should be blunt on the outer side and sharp from the inner side, while the vertical chopper is sharp from its tip. There is a nice instrument called the Akahushi pre-chopping. If you're afraid of doing chopping, is to impale inside the nucleus and just crack it into 2 halves and then 2 quadrants. The irrigation aspiration techniques is used to remove the cortex from under the capsule. Many instruments can be used for that. First, the Simcoe cannula that was developed 40 years ago, the idea behind it is to provide a method for both irrigation and aspiration together without having to rely on the phaco machine. But it's such big and no staple anterior chamber can be guaranteed. By manual irrigation aspiration, separate instruments can be present. They enter through the paracentesis and ensure good anterior chamber stability. Moreover, they are present in many sizes as 20, 21, 23 gauge. They may be smooth tipped or diamond dusted for polishing of the posterior capsule. Microcoaxial IA handpiece may be present in metal or silicon tip, straight or curved or J-shaped, as we can see here. But subincisional cortex removal may be such hard with this type of instrument. Second part of my talk is about the ophthalmic viscoelastic devices. They are very variable surgical tool, invaluable tools that must be present in each surgical in each surgery. They are substances having dual properties of viscosity of fluid and elasticity of gel or solid. So we should know about its characters. First, the viscosity, which is the resistance to flow relative to a given shear force, is determined by the molecular weight and concentration. Means higher molecular weight and higher concentration will have higher viscosity. The OVDs will be effective on moving tissues and will be difficult to displace from the anterior chamber as the viscosity increased. Talking about the pseudoplasticity, first the shearing force is the speed at which two plates are moved in relation to each other and their solution between them. It indicates the facility with which material will change the viscosity according to shear rate. If we use an OVD showing pseudoplasticity, it means with no or zero shear rate, it will have high viscosity and it can coat the tissue, and mainly the endothelium we mean. But with a high shear rate, it will lower the viscosity and become more readily extruded from the anterior chamber as we clean it. Coatability is determined by both surface tension and the contact angle. While the surface tension refers to the force acting at the interface between agent and surface, the contact angle is the angle that the drops of substance form with the surface. Lower surface tension and low contact angle result more with high coatability. That means that the OVD is good at coating the tissues, especially the endothelium. At low surface tension and low contact angle, as the right side, good coating of the endothelium is present. Last is the elasticity, which is the ability of substance to return to its original shape after deformation. It allows the anterior chamber to reform after deformation by depression on the cornea when the external forces are released after insertion or withdrawal of instrument. The higher the elasticity and the better the OVD in maintaining space. OVDs started very early in last decade, but it wasn't before the 1983 that first OVD was FDA approved, that was Helon. The ideal viscoelastic should be inert, non-toxic, easy to infuse, good retention inside the eye, although of positive pressure as during phaco, easy removal or no removal needed, doesn't interfere with instrument or IOL placement, protects the endothelium, and doesn't obstruct the aqueous outflow. Of these are four main types: the cohesives, dispersives, viscoadaptive, and highly viscous. Starting with the cohesive one, the cohesion is the tendency of the material to constituent molecule to adhere to one another rather than to disperse. The main cohesive is the sodium hyaluronate, and these agents used to maintain spaces while there are minimal movement. However, during conditions of turbulence with high shear, the long-chain cohesives tend to entangle and extrude from the eye as single mass, similar to spaghetti. So they are used to enlarge small pupils, to dissect adhesions as in the left side, and during IOL implantation as on the right side. There are many types of cohesives and with many concentration. As the concentration increase, the cohesion properties increase. On the other side, the dispersive viscoelastic, and the most widely used is the hydroxypropyl methyl cellulose. It's short-chained, low surface tension, and low molecular weight, with low viscosity and low pseudoplasticity. With high shear rates, they separate and disperse with good coating, especially for the endothelium. It's widely used, and it's the most common viscoelastic used. How would we use the cohesive or the dispersive? When the cohesive OVD is used to create and preserve spaces, to displace and stabilize tissue, to pressurize the anterior chamber with good clear view of the posterior capsule, as we are doing posterior capsular rhexis, but they have suboptimal endothelial coating, leaving the anterior chamber too quickly when the phaco or the IA is entered inside the eye. If retained after operation, it tends to increase the intraocular pressure markedly. While the dispersive viscoelastics used mainly to coat the endothelium, selectively move and isolate tissues and good partition of the spaces. On the other side, they are suboptimal in maintaining and stabilizing the tissues. Maybe the posterior capsule visualization may be not optimum with it. So when we are using cohesive viscoelastics for the capsular rhexis, for opening and insertion of the bag and insertion of the IOL, for some special cases as very shallow anterior chamber, floppy iris, small pupils, and dense cataracts. On the other hand, the dispersive viscoelastics is used during the emulsification, removal of the cortex in corneas that are compromised with poor endothelium. Viscoadaptive OVDs adapt to different behaviors that display during surgery. They have both functions of both cohesive and dispersive viscoelastics. As at low flow rate, they are highly retentive, maintaining the anterior chamber well during surgical manipulations as the cohesives, while with the high flow rate, the chain fractures and coats the endothelium very well. The viscoadaptive as the Helon 5. Lastly, the highly viscous viscoelastics. They are intermediate to high viscosity with good cohesion. They behave as cohesive viscoelastic with respect to ease of remove, but they are protecting the endothelium very well, as the Viscoat or the Discovisc. We can combine both, as in the Archinov soft shell technique, when using both lower viscosity dispersive viscoelastics together with the high viscosity cohesive viscoelastics. The dispersive is to coat the endothelium, while the cohesive to flatten the anterior capsule, minimizing the drawbacks of both and optimizing the advantages. The role of OVDs during surgery is to protect the endothelium, maintaining the anterior chamber, making the capsular rhexis easy and safe, cleaning the lens structures, cleavage of the lens structures, viscoexpression of the lens, IOL implantation, and opening of a small pupil. During special situations, as with floppy iris syndrome, using the soft shell will hold the iris in place throughout the surgery. In cases with zonular dialysis or posterior capsule break, dispersive viscoelastic can be used to make compartments of the eye and keeping the vitreous pushed posteriorly, while the cohesive viscoelastic is used to keep the anterior chamber formed and pressurized. With intramesenchymal cataract, soft shell technique, Archinov shell, is used to make the anterior capsule flat and making the surgery much more safe. But the viscoelastic is still not without complications. Postoperative rise in IOP may occur in the first 1 to 3 days if not properly removed due to mechanical resistance at the trabecular meshwork. Precipitates and deposition of the viscoelastic may make fern-like or amorphous appearance of the IOL that may need to be explanted and exchanged for opacification. accumulation of viscoelastic inside the bag formed because of PCIL optics exclude the anterior capsule opening created by capsular access. That thus leads to myopia shift and can be managed by YAG capsulotomy. Lastly, if viscoelastic has some other materials, external materials with it, may lead to toxic anterior segment syndrome in the first postoperative days. Thank you. We are going now to know the special steps of Phaco with Dr. Ihab.
You ready? Okay. So thank you, Dr. Hisham. Very informative. Basics are important for us to know when to use the viscocohesive, when to use the viscodispersive, and what are the different conditions where these conditions are to be used. Can we hook Dr. Hisham Ahmed? ممكن توصلوا؟ it's very useful to know when to protect the endothelium, when to think about flattening the capsule using the the higher viscosity tools, and when to spread the posterior capsule after doing our phacoemulsification. All these steps are important in the process of achieving a perfect or a near perfect surgery. Dr. Ahmed will talk about the phaco-dynamics now. This is very important for us to understand the machine. ممكن تغيروه تفضل تعالى. To understand the machine and to know exactly what parameters suit us. I know that we are feeling in a big loss when the when we have like several parameters and several feeding up about each technique and how to use it one at a time. But sometimes we need to stick to one thing and do the surgery in a near perfect way. So I don't really bother much about what are the setup, because I will show you later on what would be my preferred technique. But we have to know the details and the specificity of each parameter, and know and master your machine to be able to drive it. If you don't know how to use the pedal and the drive of the car, we'll not be able to drive the car, right? Or park it as well. So we really need to know about the details of of our machine to be able to conduct safe surgery, to use what and when to use it exactly. This is how Dr. Ahmed Hamdi will show us about the different techniques, and we really have to think deeply about it while making the transition and stick to one technique at a time to be able to perfect what you do. Dr. Ahmed Hamdi.
Thank you, Dr. Ihab, for this introduction. And I'm very happy that you are referring to the phaco-dynamics as a driving machine. So you need to know how to drive. And this is exactly what we are talking about, that this is like a car. Just hold on for a second to make sure that the cable is plugged in. No? Okay, can I use my cable?
فممكن اخد اسئله وتحطيني مع
Okay. Hello everyone, and welcome to this new session of our course. Today, or with this session, will be about the basic phacoedynamics. So, as Dr. Ihab referred to the phacoedynamic machine as a car, so you need to know how to drive it. This is exactly the same model or same example we are referring to. What are you looking for when you are trying to purchase a car or to drive a car? Apart from the price, you would need to think about the performance. So is this car is having the best engine and the best performance or not? Also the safety, what are the safety measures that this car could have? And finally the time. I think that the screen is cropped. Can you please check if the screen is cropped or not? The last line is not visible. Okay. So this is the same concept when we are considering phacoedynamics. This is why we are understanding phacoedynamics. You want your surgery to have a better outcome, so you want to use the less phaco power possible in order to protect the ocular structures, and you also need to have less incidence of complications. And this is what is the safety means. And also you need to perform the phacoemulsification in less time, as this will also decrease the amount of power inspissated into the eye. So the goal of adjusting the phacoedynamics parameter is that you need to know what is the irrigation. So these are the main parameters. The first one will be the irrigation, which is the source of flow inside the eye. And this is used to maintain the anterior chamber stable. The second parameter, it is the power, which is used to emulsify the nuclear material. We need to deliver efficient but sufficient also phacoemulsification power in order to emulsify the nuclear matter. And finally, the third parameter will be the vacuum, which will be necessary also for holdability of the nuclear matter, and this should be efficient, but to also not too much to avoid the post-occlusion break. Talking about the basic structure of the phacoedynamic machine, we have an irrigating bag. This irrigating bag is held upon a handle like this, and this will be connected to the IV line that will provide the phacoprobe with the source of inflow inside the eye. So this will be giving the fluid inside the eye, and on the other hand, there will be another source of line, or there is another line which is called the outflow, which will bring the amount of fluid from the eye that will pass through the phacoemulsification machine, like if it is a peristaltic pump, or it is one of the modes of phacoedynamics machine are the peristaltic pump. So there will be some rollers. These rollers will be responsible for milking of the fluid from the outflow line that will collect this fluid into collecting bag. So the basic principle of the phacoemulsification is that we need to have we have two fluid currencies. The first will be the inflow from this bag, and the other will be the outflow. So let's put this into context in a real phacoemulsification machine. This is the famous and the popular Alcon Infinity machine. You can see what is the basic structure we have here. This is the fluid, the source of fluid or the source of inflow. And this is the screen showing the main parameters of the phacoemulsification. And this is the collecting bag, and also with the cassette and the rollers. And finally, there is the photo switch. So here the surgeon can control the different steps of the surgery. So the basic principle of phacoemulsification is the balance. We need to have a balance. The eye is a closed chamber, so there is a source of fluid that is coming inside the eye, which is the inflow, and there is also outflow from the eye. We need always to make sure that the inflow is equal to the outflow, or more preferably that the inflow will become more than of the outflow. And why do we need this? This is because that way we are avoiding a major problem called surge that we will talk about at the end of the session. So let's start first with the first parameter, which is irrigation. Irrigation, as we mentioned, it is the source of fluid that is coming to inside the eye. And this irrigation control in most of the Phaco machines is not linear, meaning that there is no button that you are just click on it, or there is no foot pedal that you are just pressing on it that will cause linear increase in the irrigation. But mostly it is determined by the bottle height. Some devices like Centurion, for example, have active fluidics that you can control the pressure of the fluid, but this is not the case in all devices. As we know, that this source of fluid should be higher than the outflow. And why this? This is because that the decreasing inflow inside the eye will have some problems. For example, like the wound burn. You know that the phaco probe is producing some sort of energy. This energy causing heat, and this can damage the ocular structure, can cause burn of the endothelium. So the virtue of this irrigating fluid that it will cool the phaco tip as it passes through beneath this sleeve, causing a cooling of this heat effect. So you may think of, okay, why wouldn't we always increase the bottle height to the maximum, and why wouldn't we always increase the inflow maximum to the maximum level? This is because that the increasing the inflow more than necessary also has its hazardous effects. So we don't want a high pressure jet flow to enter inside the eye, because that this can cause damage to ocular structure. So this sometimes when you have a high jet flow entering inside the eye, this can cause damage to the endothelium. And also you can find sometimes that the nuclear matter are repelling. They are giving away from your phaco tip, and you wonder why. But the answer is that the flow is what makes the nuclear matter repulsion. Also, those who have myopia, especially those who have high myopia, already have deep anterior chamber, and this will also, if you are increasing the bottle height, you are causing further deepening of the anterior chamber, which will make it unstable. So avoid high bottle height in myopes. The second parameter will be the aspiration flow rate. The aspiration flow rate is the rate of fluid removed from the eye. So as we said that there is some sort of flow inside the eye, the counteract or the counter effect will be some sort of fluid that's coming out of the eye. And this aspiration flow rate will determine the speed of events that occur in the eye. Let's say that you want that everything in the eye, this is the amount of fluid aspirated from the eye, and you want that everything inside the eye occur by slow motion. When you want everything to be slow motion, what you need to do is just to decrease the aspiration flow rate. There is a misconception that when we are talking about the speed of events inside the eye, and I can't find that the nuclear matter are coming toward my phaco tip, then I increase the vacuum. This is not true, as the vacuum is responsible for holdability. On the other hand, the aspiration flow rate is the parameter that is bringing the nuclear material toward the phaco tip. So if you want everything to become faster, so you want to finish the surgery faster, then you increase the aspiration flow rate. But this is not without complications, it is not without a cost, because this also can make events, even the adverse events, happen faster. Like if the phaco tip attracts the posterior capsule, it will be faster, maybe more than the way you will be able to handle. The aspiration flow rate in case of the phaco-dynamics machine that's acting by peristaltic pump will be based on rollers. So we said that there will be rollers that are causing milking of the outflow tube, causing drawing of the fluid from the eye into the collecting bag. So if we are increasing the aspiration flow rate, this will increase the speed of these rollers, and vice versa. In some devices, you might find that the aspiration flow rate have some fixed control and linear control. You can find that this is the fixed and this is the linear. And so why do we need a fixed and why do we need linear? Sometimes when you are dealing with a quadrant removal or a sculpt, this is we need a consistent and a predictable flow attraction. On the other hand, if we like, for example, if we are removing the epinucleus, this is require more control. So we need to make that it is linear. As we the more we depress, the more we get aspiration flow rate, and the less we depress, the less we get aspiration flow rate, and this will be important to guard against rupture of posterior capsule. The third parameter will be the vacuum. So the vacuum is the negative pressure inside in the aspiration line. Meaning that, like any vacuum, when you have a vacuum like the vacuum cleaner and you are cleaning your carpet, this vacuum cannot remove the dust from the carpet unless it is very, very close to the carpet. And this is the same thing that happens with the vacuum of the phaco machine. Meaning that in order to build up the ultrasound power, there should be an occlusion. The phaco tip should be occluded by the nuclear material, and what will be responsible for this occludability? This will be the vacuum. So the vacuum will build up once there is occlusion of the phaco tip, and we don't need more vacuum than necessary. So just not to be confused about the two terms of occludability and holdability, what brings the nuclear matter to the phaco tip is the aspiration flow rate, while what makes the phaco tip having good grip and good hold of the nuclear matter so that it can move freely in the anterior chamber, and it can, like, for example, you want to move it in order to shop it by the second instrument. This is what is the rule of the vacuum. So the aspiration means that how quickly nuclear material is attracted to the tip, while the vacuum means that how tight is the tip holding the nuclear matter once it is occluded. There is another important parameter or important thing about the phacodynamics, which is the tubing. You can see here, if you are closely observing these tubes, this is the outflow tube and this is the inflow tube. You can see in the first instance that the outflow diameter is more than the inflow diameter is more than the outflow, and this is expected. As we said, we want always that the inflow becoming more than the outflow to avoid the surge. But what I wanted to draw your attention to is even the thickness of the tube. You can see that the thickness of the outflow tube is more than that of the inflow. So is it on purpose? The answer is yes, because the thickness of the tube will be responsible of what's called the compliance. What is meant by compliance? The compliance is just to be affected by external pressure, and we don't want the outflow to be affected by external pressure, as this can cause what's called surge. So the problem is what's called the post-occlusion break. When we have, we have a flexible tubes, or we have a compliant tube, this compliant tube will collapse upon the high pressure of the outflow. So the problem is not within the collapse, but after the break of the collapse. As after break of the collapse, this will cause the flexible tube to swell and remove large amount of fluid from the eye, causing loss of the pressure inside the eye and rupture of posterior capsule. So let's illustrate this in more details. If we have here a phaco tip and it is occluded by the nuclear matter, what will happen? If the tube is compliant, this will cause the increasing the negative pressure inside the tube, and the tube will collapse. And what happens then after removing of this nuclear matter, or after emulsification of this nuclear matter, this tube will expand. And this expansion of the tube will draw much more fluid from the eye, causing the surge. So the surge is meaning that it is an event in which there is the inflow less than the outflow, and this can be determined by the several factors like the tube size. As we just mentioned, we want the tube size of the outflow to be less than the inflow, and we want the tube size of the tubes of the aspiration to be non-compliant. Also, the bottle height, if we increase the bottle height, we're increasing the inflow. And if we the sleeve size also, if the larger the sleeve size and if it is leaky, this will decrease the inflow, so it should be well fit to the phaco tip. And also, if we have the higher aspiration, this will increase the outflow. If we have leaky ones, this will cause outflow. Let's just see this video where there is you can see that there is a momentary constriction of the pupil. This momentary constriction of the pupil occurred due to the surge. This surgeon has this anterior chamber unstable, and this is evidenced by this momentary constriction of the pupil, leading to this can predispose to side effects like rupture posterior capsule or damage to the corneal endothelium. Finally, the final parameter will be the ultrasound. So the ultrasound is the amount of is like an ultrasonic vibration that is transmitted to the phaco tip, leading to emulsification of the nuclear material. We need to know that we should use the least amount of ultrasound possible, as this will avoid the damage to the intraocular structures. Another thing important about the ultrasound is that it has a repulsion effect. Sometimes when you have high excess or excess ultrasound energy and you are approximating it toward a nuclear matter, this nuclear matter will be moving away. This is because the ultrasound has a repulsion effect, or has this making the nuclear matter moving away. We need to use the least ultrasound power. According to the direction of the ultrasound, we have the longitudinal or jackhammer effect, the torsional or the ozyl, and the transverse or the ellipse. So what is the mechanism of action? The jackhammer effect, it is like a longitudinal movement, and they cause emulsification of the nuclear matter by longitudinal movement of the tip. And this can result in excess ultrasound energy, and this mode will present in most of the devices. But another mode is called the transverse ultrasound or the ellipse, where the phaco tip will move by horizontal movement. And the third one, or the third direction, will be the ozyl, as present in the phaco infinity, which is a torsional ultrasound, which can cause shaving movement. This shaving movement will cause removal of the nuclear material, and even without the need of use of longitudinal ultrasound power. According to the mode, we have different modes of the ultrasound. We have the continuous and the pulse mode and the burst mode. For the continuous mode, it means that there is linear control over the ultrasound power. So the more we depress on the foot pedal to step 3, the more we get of the ultrasound power. And this is suitable for some phaco techniques like the sculpting. But as we said, there is some shattering effect or repulsion effect of the phaco power. So this shattering effect will cause the nuclear matter to be moving away. And that is the virtue of the phaco pulse. As the phaco pulse, there is alternating on and off periods of the phaco power, so that this off power will cause the nuclear matter not to be moving away from the phaco tip. So this will be helpful in case when we are needing to emulsify the nuclear material, as during the quadrant removal. The third mode is called the phacoburst, and the phacoburst, there will be also alternating on and off, but the time between on and off is decreasing as we increasing the depression on the foot pedal on step 3. So the phaco power will be in pulse mode at the start, and at the end it will become continuous. So this will be more useful for experienced surgeons, where they just use one mode to handle all the steps of the surgery. So the foot pedal is the one that under your leg, that you can control the steps of the surgery. For the step 1, you are just doing irrigation, and for step 2, this is irrigation aspiration, and finally the step 3 is irrigation aspiration with ultrasound. So you need to know what is the appropriate step for each step of the surgery. Let's say, for example, that you are still entering in the anterior chamber. In this step, you are using the step 1, which is the continuous irrigation. If you are doing sculpting, then you are doing the step 3, so you are pushing the foot pedal to the maximum, so that you are pushing the ultrasound power to the maximum, so that you can create the groove. And at that stage, you don't need high vacuum, as you are not attracting the nuclear material and you are not emulsifying. This is on contrary to the step 3. In step 3, you need to have a good grip of the nuclear matter, so you don't want repulsion or the shattering effect of the ultrasound power, so that you are moving between step 2 and step 3, and you are using mainly the pulse mode. So this is a brief overview of the phacoDynamics, and for the more information, I recommend you this book. It is phacoDynamics by Seibel. This is a very illustrative and very informative book that will give you more information about the more details about phacoDynamics. Thank you very much.
Thank you very much, Dr. Ahmed. I'm always getting confused about the issues, but I think, you know, we have Dr. Oyelai and Ugendipi with me. The fear comes from the heat, you know, the ultrasonic power that is generated from our phacotip, our phaco handpiece, and the fear that we can burn everything, starting from the incision to the endothelium, to the capsule, to everything. So this is the instrument that is really beneficial and can be hazardous. So the fear of making the step is to know exactly how the flow is maintained, how the vacuum, what's the aspiration flow rate, and Dr. Ahmed demonstrated beautifully the differences in each of the nomenclature and the techniques as well. But this will be number one. Number two, you have always to be conscious and alert about maintaining the depth of the anterior chamber. And they simply think about the bottle height and the speed of fluid and debris coming out of the your phaco handpiece. And this is the second most important step. So if you're stuck and you have that, you know, more tissue than they should be coming to your phaco handpiece, ask the nurse to elevate the bottle height. This will deepen the anterior chamber and allow you to check what's going on wrong. So this is another extremely important step. Remember about the viscoelastic Dr. Hisham Gharib talked about earlier. They are very useful in certain conditions and circumstances, and always be on the safe side. And I think if you start your phaco, deal with one issue at a time. So if you have a hard cataract and a narrow pupil, don't do it. Do it the usual way. If you have a narrow pupil, you can deal with that. If you have a hard cataract, you can deal with that. If you are in different circumstances, cataract as well, you can deal with that. So maybe my co-moderators would like to add something to the first two presentations.
Those were beautiful, presentations. It's very important that you get the basics very right before you proceed into doing phacoemulsification, because it is the understanding of the science of this phaco-dynamics that will help you to prevent complications. And also, when complications come, you know what to do immediately. You know the level at which to stop. You know what you need to control once it starts, you know. And then the other thing is that you use all your senses, or I'm sure Dr. Ihab will be going to that. All your senses when you are doing phacoemulsification. Your ears must be very sharp to listen to the different changes in sound. You must be able to feel even with your hand when you are not your nucleus is not occluding and you are not having the effect you want to have. And also you must be able, to have the feel on your feet so that when you are beyond level 1, then you know that you may likely get a shallow chamber when you are not looking for a shallow chamber. And when you get to level 3, you may be cutting what you don't need to cut because you've gone beyond the level 2 that you were supposed to be working on. So all these are very important as you proceed in the procedure. Thank you.
You know, people from Africa are wholehearted, and this is why we do a wholehearted phaco, using all our senses at the same time. This is a good tip, Dr. Ogundipe. May we continue with the phaco steps, and we'll get back to the co-moderators for further comments. Dr. Hamdi.
Okay, thank you, Dr. Ihab. We are on. Okay. Okay, so we will start now with the basic steps of the phacoemulsification. We will not go through much details. This will be the for second sessions or the next sessions. Let's know now what are the steps of phacoemulsification. The phacoemulsification starts first by the preparation. So after the patient receives the proper type of anesthesia, like the surface anesthesia or the peribulbar or retrobulbar or subtenon, then there will be adequate draping and sterilizing of the ocular surface. So this is one of the important tips in order to avoid the risk of endophthalmitis, and this is what one of the most proven and evidence-based methods to prevent or to decrease the rate of post-operative endophthalmitis by appropriate draping and putting the lashes away from the surface of the eye and opening the eye with the speculum. Then you need to have an axis inside the eye, so this is the rule of the paracentesis. The paracenteses are basically side ports. These side ports are astigmatically neutral. Yeah, they are usually around 1 millimeter in depth, and this will be allowing the access to the eye. They can be manufactured using several instruments like the microvitreoretinal blade or a super blade or the tip of microkeratome. So as you can see here, this is the MVR, and this is allowing an access inside the eye. After stabilization, you can stabilize the eye using the limbal fixation ring or using a counter pressure from the other side by using like colibri forceps or so. Then after that, you are now want to form the anterior chamber. After you open the anterior chamber, the pressure will be extremely low. So you need to form the anterior chamber using the viscoelastic devices, as Dr. Hisham has illustrated. And we have, as he mentioned, we have two types of viscoelastics, where everyone has specific rules and specific functions, like the cohesive, like the helon, and the dispersive. So the cohesive will cause more flattening of the anterior lens capsule, and while the dispersive will be more of coative function, so it will be used for protection of the endothelium. Sometimes both of them can be used together, which is called the soft shell technique. When you are injecting the viscoelastic, make sure that you are injecting from inferior or from the far end all the way down as you are getting out of the needle. So you are making sure that the visco bubble is enlarging and expanding all over the anterior chamber. It is all filled with viscoelastic. So you don't have a lost anterior chamber, as you will need a formed anterior chamber in the next steps. Sometimes when you don't have a good visibility to the red reflex, you can use a stain to the anterior capsule, and this is when you need to stain the capsule. Can be done by the trypan blue. For example, you can see this video when we have here a white cataract and there is a lack of visibility to the red reflex. After we get access to the anterior chamber, with the surgeon here inject the air bubble to protect the endothelium, and then we inject this stain called the trypan blue. This trypan blue will cause a beautiful staining of the anterior lens capsule in order to have a good contrast between during the capsulorhexis step. After that, after 10 to 5 or 5 to 10 seconds, we remove this stain by just irrigating solution, and then we can remove this bubble if it is still present. And finally, we can inflate the anterior chamber using the viscoelastic. So here we can first start with the dispersive viscoelastic to coat the endothelium, followed by this is the dispersive viscoelastic, and then we can fill the anterior chamber with the cohesive viscoelastic in order to flatten the anterior lens surface for this case of white cataract. And then we will need to get access for the corneal incision or the scleral incision. So we have two types of incision. We have the clear corneal incision or scleral incision. How can we do the corneal incision? This can be done by stabilizing the globe, as we mentioned, by this limbal fixation ring, or using a counter pressure by like cotton tip or a forceps. And then we can now introduce the microkeratome. This microkeratome, we need to know what exactly the size of this microkeratome in order to be comparable to the phacotip size, and then introduce it into the anterior chamber and in either one in uniplanar or biplanar or 3 levels incision, so you can fashion the incision in a lamellar fashion in order to prevent the collapse of the anterior chamber. As you can see here, this is the surgeon is creating the incision using 2 steps, and now is entering inside the anterior chamber. It is very important to know that this incision is one of the crucial steps in the surgery, as it doesn't have to be too long or too short or too wide or too narrow, too superficial or too deep, because every one of these options or these mistakes can cause some difficulties in the surgery. The other option, if we don't want to have much astigmatism after the surgery, will be a scleral tunnel. And the scleral tunnel is fashioned by making a periotomy. So we open the conjunctiva, then we are cauterizing the blood vessels, then we measure the size of the incision, making a front incision, and then using a blade, then fashioning a tunnel using the crescent knife. So as you can see here, this is how we make a periotomy, like opening of the conjunctiva, and then creating then cauterizing of the blood vessel to minimize the bleeding, as you can see here. Then we can create the measuring the our incision, which is like that. Then create making by a super blade like 2 millimeter from the limbus. We are using the super blade or a blade to create a front incision, and then using the crescent knife, it will be fashioning a tunnel in order to open the anterior chamber, and this can be done after we fashion the tunnel. We open the anterior chamber using the microkeratome as usual. So it is this side-to-side movement is very important in order to maintain the same plane that you created using the crescent knife. After that, we then one of the most important steps in the surgery is the capsulorhexis. The capsulorhexis is one of the very important steps during the surgery, and it will make the rest of the surgery much easier or much more difficult. To make it much more easier, there are some basic steps that we need to know. First, it has to be central, it has to be rounded, and it has to be continuous with no breaks or no tears, and this can be achieved by 2 main instruments. One of them is called the cystotome, and the other will be the forceps. So let's see how can we fashion a continuous curvilinear capsulorhexis using the cystotome. So the initial scratch is made by the cystotome, which is a bent insulin syringe needle or a 27 gauge needle. So you are creating a flap at the first instance, and you are making the flap is as flat as possible. So you don't want the flap to be elevated, and you are now moving. Let's repeat this again. And then you are advancing the flap in a curvilinear fashion in order to create a central circular opening in the anterior capsule. This is one of the easiest way to fashion the capsulorhexis, and this is usually the method preferred by beginners. As the second method will be the forceps, as the forceps is more bulky and needs more experience in order to control. And you can create also the initial scratch using the capsulorhexis forceps, but this can risk some disturbance of the cortex, which may be not favorable by beginners at the start. And then again, you are grasping the capsule at the junction between the attached and the fixed edge. So every time you are grasping, you grasp and re-grasp until you are complete the capsulorhexis, and you are closing it from outward, so that you are ended up by a heart-shaped capsulorhexis and not closed it from inside. Sometimes you may think that, okay, I need to just master one of these techniques and no need to learn the other. Sometimes it is important to know how to use each of these instruments, because in some situations you can use both of them together, as you can see in this video. So you can see that the surgeon is starting the capsulorhexis using the roxis forceps, but he is losing the anterior chamber. chamber because he is pressuring by this bulky instruments over the posterior lip of the wound, causing the viscoelastic to get out from the anterior chamber, which will risk extension of the rhexis. So he decided to stop doing the capsulorhexis with the forceps, but to use the needle instead from the side port so that he can have more stable anterior chamber. Also, if you are wondering how to manage a subincisional capsulorhexis, or if the edge is present at the subincisional area, this will be difficult to manage with the needle alone. This should be managed by the capsulorhexis forceps to have a good grip over the rhexis. So here also we have in this case there is a running rhexis, and you can see that here is the edge of the rhexis, and you cannot retrieve it using the needle the needle. So here is come to the rule of the forceps, as the forceps can grasp the capsulorhexis edge and they can change the direction. This is very important as it can cause the ripping of the edge of the rhexis, and this will be difficult to do with the needle alone. So in the different scenarios, it needs different maneuvers, and different situations will require different interventions with different instruments. After successful completion of the capsulorhexis, then we will again come to a very important step, which is the hydrodissection. Hydrodissection basically is the separation of the lens cortex from the lens capsule, and this can be done by advancing this needle beneath the anterior lens capsule and injecting a jet of fluid that will pass beneath the capsule to separate the lens cortex from the posterior capsule. And this can be ideally done by this syringe 26 to 30 gauge needle, but the 27 gauge needle, which is the Helon, will be the ideal one. So how can we do or how can we know that we did a successful hydrodissection? This can be achieved by observing the wave of the fluid. So the wave of the fluid, you can see that it will pass beneath the posterior capsule, and if you can see that the wave of the capsule is separating or extending all over the lens, this means that there is a good separation. And to make sure also, you can rotate the nucleus by using the needle tip. If there is good rotation, again, this means that there is a good separation of the cortex. Another important thing here is once you are injecting, you should press down the nucleus in order to release the fluid trapped behind the posterior, behind the lens, in order to avoid what's called the capsular block syndrome. In some cases, hydrodissection is not done for every case, as we said in the previous time, that the posterior polar hydrodissection is contraindicated. So hydrodelineation will be much better option here. So usually we do hydrodelineation in most of cases, which is a separation of the nucleus from the epinucleus. It is done by the same technique, but you are just advancing your needle a little bit deeper so that you are separating the nucleus from the epinucleus. And by injecting the fluid, this can result in appearance of the golden ring. And this golden ring means that there is a successful hydrodelineation. For the nucleus disassembly, there will be several techniques, as it will be discussed by Dr. Muhammad Ibrahim, so we will not go through this, but the most basic technique will be the divide and conquer, where we are creating a cruciate-shaped grooves within the nuclear matter in order to separate these the 4 quadrants and attack each quadrant by itself, so that we can remove the nuclear matter piece by piece. So basically the nuclear disassembly, meaning that we are removing the nuclear matter piece by piece by several ways. This can be done by divide and conquer, like stop and chop, like chip and flip. Different maneuvers can be used for different phacoemulsification, different kinds of cataract, and also based on the experience of the surgeon. After removing of the nucleus and the epinucleus, then we will come to the cortical aspiration and the corticapsular polishing, and this can be done by either coaxial. So if you have coaxial irrigation and aspiration, this can be used, but actually it has a disadvantage that it can't access the subincisional area. So you remember the 2 side ports that we made at the beginning of the surgery. They will be extremely useful now, as we can put inside the irrigation and aspiration cannula. We are always putting the irrigation first and removing it last. So we put the irrigation, then we put the aspiration. But when we are removing them, we are removing the aspiration first, and finally we remove the irrigation. This green area is the area where the aspirating probe can remove the cortex. So we need to switch hands in order to gain access to all areas of the eye. As you can see here, this is the bimanual irrigation and aspiration. So as you can see here, the surgeon is trying to remove the subincisional cortex and other cortex. This can be done from the periphery toward the center. So you just grasp a cortical matter, and then you are moving it toward the center, not the reverse. The other way is just which is more commonly used, which is the bimanual irrigation aspiration. So we advance the irrigation cannula, and the aspiration is just sweeping all over the eye in order to remove the cortical matter. And when we are finishing the temporal half, we are moving now to the nasal half, or vice versa, so that we complete both sides. After successful removal of the cortex, we now need to insert the intraocular lens. There are two main methods to insert the intraocular lens. One of them can be used to use a forceps. So you can, if it is a foldable intraocular lens, we can use a forceps in order to advance it inside the eye. Or the other way is using an IOL injector. So when we are loading the intraocular lens inside the injector and inject it inside the eye. So this is how it looks like when we are using the forceps in order to put the intraocular lens inside the bag. As you can see here, it is unfolding. And then using a second instrument like a Sinesky or a dialer, you can put or make sure that both the trailing haptic and the optic is inside the bag. So this is very important. Or the more common method is using the lens injector. So after loading of the intraocular lens inside the injector, you are just doing, you are either kissing the wound with the tip of the injector, and you are injecting the IOL, so that you are making sure that the leading haptic is inside, and with the use of second instruments, you are make sure that all the intraocular lens is inside the bag. Or the other way is you are just putting the intraocular lens inside, or some injectors can be advanced inside the bag, so that you can inject the intraocular lens inside the bag. After that, you are removing the viscoelastic. So removing the remaining of the viscoelastic from the anterior chamber, as you can see here, after intraocular lens implantation, you can remove the remaining viscoelastic, so that they will not cause rise of the intraocular pressure after the surgery. If you are experienced enough, you can go behind the intraocular lens to remove the retro IOL viscoelastic. And finally, you are now want to make sure that everything is good and clean, and you are closing the wound. So the wound is closed by you are testing the wound if there is leakage, and if there is any leakage, you are closing the wound using the irrigating fluid. So this can be done by stromal hydration. So using the needle, you are hydrating the stroma, leading to this whitening. This shouldn't be excessive hydration. This is just a simple hydration, minimal hydration, just to make sure that the wound is watertight. And for some surgeons, they don't prefer to hydrate the main wound because it is theoretically self-sealed. But for others, they are testing it, and if it is some sort of leaky wound, then they can minimally irrigate it just to make sure that the eye is closed, the pressure is preserved inside the eye. Should you find that there is a need to excessively hydrate the wound, this means that the wound are not self-sealed, and they are not they don't have a good architecture. So you may consider closing the wound with a suture in order to prevent a leaky wound, which can cause hypotony and risk of the post-operative endophthalmitis after the surgery. So to summarize, the phacoemulsification can be considered like a pyramid. In the pyramid, every step is dependent on the previous step. So the first step is like incision. If you have a poor constructed incision, like if you have a short incision or long incision, this can make the long incision can make the capsulorhexis difficult. The short incision can make the iris gets out all the time during the surgery. So the second step, the capsulorhexis, if you make the capsulorhexis eccentric or small, this can lead to risk of attracting the edge of the capsulorhexis with the phaco tip. The third step is the hydrodissection and hydrodelineation. If you didn't do a proper hydrodissection and hydrodelineation, this will cause excessive cortex that is attached to the capsule, and will risk rupture of the posterior capsule if you are not careful enough. The step 4 will be the nuclear disassembly. Again, if it didn't managed with care and with consideration, this can cause a rupture of posterior capsule as well as the irrigation aspiration and the intraocular lens implantation. You know, sometimes the intraocular lens implantation itself can cause rupture of posterior capsule if it is some injector cause shooting of the intraocular lens during the surgery. So even you don't feel safe until the last step of the surgery while you are closing the wound. This will cause closure and also careful closure of the wound will prevent even post-operative complication as endophthalmitis. And thank you very much.
Thank you very much, Dr. Ahmed, for the beautiful steps in Phaco. As Dr. Ibrahim is proceeding with the techniques now, I think the last slide is the most important slide in your presentation, and really you have to be fully attentive to each and every one of those steps. I would add even the anesthesia, the anesthesia slide or footstep as an initial preparation for the ongoing procedures of phacoemulsification. So the beauty of each step is to have 100% concentration on the wound design, very important on each and every step of the phaco techniques. And if it goes right, everything will go right. If one technique is wrongfully done, it will be, it will be disastrous for the next steps, and will start to be very discomfortable in proceeding with the surgery. So there are really different techniques in phacoemulsification, and we really have to stick to one technique and make sure that we'll be comfortable with and consistent with, and then try something else according to the different needs and the different situation we are faced and we are in. And really, this is how you gain your experience in phacoemulsification. The other important issue here is the try to minimize complications and always think about patient safety as the first priority. It's not important to do phaco. Remember always that it's important for the patient to see. And this is the essence of our practice as physicians, is the do no harm policy of patient really has to see, and we're using the least maneuvers and the least possible manipulations, and not by doing phaco. So this is a very important step in carrying on surgeries and cold phacos. And carrying on the surgeries. Yeah, sure. We have questions about cold phaco. Well, this is a very important question. I think, my preferred technique is the quick chop technique, and I always use the micro burst mode. So in the burst mode, if you have the whole length of the linear phaco as a wave phaco and emulsification ultrasound emitting envelope, we use only 10, 20, 30%, and with the cycles of 70% cooling off at 30% phaco power. So this is using the minimal phaco, and within the same period you use a very long cooling time or a shorter cooling time, and not using ultrasound for the whole length of the procedure. Maybe Dr. Oilai would have a comment on the presentation and the cold phaco. Abiola, are you there?
Thank you very much. Dr. Ahmed, thank you very much. You showed us some pyramids. I was waiting for the pyramids of Egypt to be shown. However, just a few tips or a few comments I want to make. I think one very important comment is when you are converting from small incision cataract surgery or extracapsular extracapsular cataract surgery to phaco, one very important thing is the choice of your viscoelastic. A lot of people think the dispersive viscoelastic, like the HPMC, is the same as the Helon. The cohesive ones is very important. You need to deepen your AC, and that's why it's very different when you're doing this compared to the HPMC. Another thing is you showed us a video of a white cataract. When one is faced with that challenge and you use your tryptan blue dye, whilst you're doing the phacoemulsification, there is this tendency that the capsulorhexis is running out. So one must always remember that. And if you need to refill your AC with viscoelastic, then refill the AC so that you don't lose the capsulorhexis. And another thing to be careful about, I think, is you need to know your blades and you need to know your phaco machine. I use a phaco machine with a 1.8 millimeter. So I use a 1.8 or 1.7 millimeter blade. Assuming your section or your incisions are too big, you will get a lot of leakage. And just like the first talk we had, when you have a lot of leakage, then your eye will collapse during surgery. So it's very important. There are little things. I think a lot of things have been said here, but each topic or each section of Dr. Ahmed's pyramid, each section is very important, and you can have a lecture on each one. So the important thing, as Ehab said, take it slowly, then one step at a time. Thank you.
Just to be very quick, the way I look at the visco is it has to collapse the anterior lens capsule so that the axis would not slip away. So if I don't have Helon, the cohesive, I use the dispersor, I use methyl cellulose, and I do my axis through the paracentesis. So now the methyl cellulose act as Helon because everything is watertight, so it does not slip away. One important thing that Ahmed beautifully showed as well while doing the axis is you're focused on the capsule, so you don't see what's going on the wound side, and there is always leakage. So try to have the upper lip of the wound as a fulcrum instead of having the lower lip of the wound and having the visco going out each time. And we have flattening of the anterior chamber and then slippage of the axis away. So many tips as we learn and as we just learn them by time and hopefully not the hard way. Mohammed Ibrahim is going to show us the phaco techniques. He's really mastering those and we always enjoy his lectures. Mohammed.
Thank you, Professor Ehab. Thanks everyone for attending our second webinar. I'll now start talking about phacoemulsification techniques. Usually we classify phacoemulsification techniques into non-fracturing techniques for soft nucleus and nuclear fracture techniques for hard ones or harder ones. As Professor Ehab said, we don't have to master all techniques. We just have to know enough techniques to manage different cases. Not everyone is mastering all those techniques. Non-fracturing techniques include chip and flip, debulking technique, supracapsular phaco. I'll just show you some videos to discuss some of those techniques. This is an example of a soft case. In soft cases, I usually prefer to do a bit larger axis or at least an adequate size axis, and then do multiple waves of hydrodissection again and again and again until I'm dead sure that it's completely loose of the capsule. Then usually if it prolapses out of the bag, I let it out. In harder nucleus, usually you reposit it again. In soft ones, no. I make use of this supracapsular technique. Usually it's enough doing a vacuum or even a little bit of ultrasound. It's usually gone. This is an example of supracapsular non-fracturing techniques. Just use your vacuum. Another example is, again, a soft case. I did hydrodissection, hydrodelineation, multiple waves, and then it's prolapsed out. In this case, it was not completely prolapsed. Sorry. It was not completely prolapsed out, just one edge was out. So I started injecting a lot of viscoelastics, and then I will start debulking technique. I'll eat it in a piecemeal fashion, piece by piece, slowly. Do not be eager to eat it completely in one press or on one foot pedal press. Just keep going slowly. And take care that soft nucleus can be eaten slowly, can be eaten easily, and then the capsule can come after it. So just keep very cautious, piecemeal, and then you can prolapse the epinucleus out of the bag as you see. Okay, this was a soft cataract. In nuclear fracturing techniques, usually this is applied in nuclear 2, 3, and 4 and harder ones. This can be classified into divide and conquer, stop and chop, quick chop techniques. This can be classified into horizontal or vertical chopping, and we will show all these techniques. Of course, again, you should not master all these techniques. You should master the techniques that conquer every case with you in your hands. Starting by divide and conquer. In divide and conquer, we make two grooves, two trenches, 180 degrees. These grooves are then used to make the nucleus into 4 quadrants. During making the grooves, you should use high ultrasound and only low vacuum. The width of the groove should not be very wide. It's only 1 or 1.5 the diameter of the tip. But it should be deep enough, 2 or 3 tip diameter, until you can see red reflex in the depths of the groove, so that it can be fractured easily. You go superficial in the groove, and then you go deeper. Don't go deep at once. And follow the curve of the posterior capsule. Take care that the posterior capsule is deepest in the center, but it's superficial in the periphery. As you can see, you put your instruments in the groove, not superficially in the groove, but put it deep down below in the groove, so that it can fracture the nucleus. This is an example of a case, nuclear 2 to 3. Usually you eat the epinucleus above the nucleus, and then start making the groove. As you see, you go superficial, and again, then you go deeper and deeper again, until you can see a good deep red reflex. Here you can fracture now, or you can rotate and make another groove 180 degrees. In this case, I rotated, and then started creating another groove perpendicular on it. Now, if you fracture those, you have 4 quadrants that you can eat easily. This is another example of a case. It's a harder one, so I started creating a groove slowly. Do not use high vacuum, only high ultrasound and low vacuum. Keep going deeper and deeper until you see red reflex. Now I think red reflex is seen, so I'll fracture it now. And it's now in 2 halves. In this case, I continue doing another groove, so it's still divide and conquer. I'll rotate and do another groove. Again, you should not use high vacuum. As you see now, the nucleus is now aspirated towards me. This should not happen that way. It should only be, the vacuum should only aspirate the emulsified material and not pull on the nucleus. And now you have 4 quadrants to tackle. This is called divide and conquer. Okay, the next technique is stop and chop, and this means stop dividing and start chopping. You will only make one groove, and then each half is chopped and not grooved again. As you see, I created only one groove now. There is red reflex down there in the center. So I'll fracture those into 2 halves. And then use my chopper to just fracture the nucleus without creating another groove. In this step, you need a high vacuum and moderate ultrasound, not very high so that it does not eat the nucleus, and not very low so that you can impale into the nucleus. Now I fractured it without creating a groove. This can save you from using a lot of ultrasound, especially if this case has a poor endothelial count. The quick chopping techniques are either quick horizontal chopping or quick vertical chopping. In these cases, we do not create any groove. We just use high vacuum to hold the nucleus in place and then use your chopper to fracture directly without grooving. This is an example of horizontal chopping. You use a blunt chopper, you impale into the depths of the nucleus and go with your chopper at the equator and push toward the phaco tip. Now it's fractured without grooving. This saves, of course, a lot of ultrasound. Again, go with your chopper at the equator and fracture. You can fracture as many parts as you want, not only 4. You can make it 6 or 8 as you wish. And this is another example, exactly the same. The vertical chopping, you do not go by the blunt chopper at the equator. You just impale the chopper into the center of the nucleus, just in front of the phaco tip. And then you make side-to-side movement. The chopper pulls to the left and the handpiece pulls to the right. You just impale in the center and then use high vacuum with your chopper, impale in the center and pull towards you. This was just an example of vertical chopping. Then you should tackle your epinucleus. Your epinucleus use moderate vacuum, low ultrasound, and avoid eating the capsule in this step. This should go very gentle. Take care that the epinucleus is very soft. It can be eaten followed by the posterior capsule directly. You can rotate it until you can get it out of the bag and then eat it safely. Once it's out of the bag, you can press your foot pedal. And now we're done with our nucleus and the epinucleus. Thank you all.
Thank you very much, Mohammed. You're right to the point, which is great about your presentations. So we had a question about the cold phaco, and I think the quick chop or the vertical chop would reflect what we use as minimal power phaco. You know, for those hard cataracts, if you break them, you can get them easy and very sharply with a minimum power phaco. Just a tip I learned for the quick chop is when you go with your phaco handpiece to induce some aspiration, some vacuum, to hold the nucleus. Your left hand holding the chopper should be already ready in position. I think because the holdability of the vacuum is low when you're dealing with the whole lens. So my left hand is at the equator with the chopper in position and ready to fracture the nucleus as well. Very informative, and as we move on to my next presentation, are there any comments from either the audience or, we have a very important question coming in, and Abiola and Buddy would like to answer it, and Mohammed as well. What would be your phaco time in the worst cases? Because I have another answer for that question as well. So if you have a hard cataract, for instance, what would be the whole procedure time if you're sitting on from incision to ending the surgery?
Actually, we all seek rapid phaco, but this should not be the target. You should be always aiming at the safety of the patient, doing a procedure in a good way with optimum outcome. There is no problem to take half an hour, even 45 minutes if it's a hard, complicated case with a lot of procedures. Not every case will go in 5 or 10 minutes. Sometimes some cases can take a longer time. I don't bother myself. I just keep doing safe phaco until it's finished.
So his time is 5 to 10 minutes. He's only shy to say it, but I know he's a really fast and very habile surgeons as well. Abiola, do you have did you like kind of monitor to go on Guinness records or something?
It takes as long as it takes, basically. Any cataract surgery takes as long as it takes. I don't think you should look at the clock, because otherwise you put yourself under pressure. The important thing is the patient with you there and doing a successful operation. Thank you.
You know, I'm ready to be fast and to be sharp and to finish as soon as we can, and you know, be ready to the surprises. So I will show you what I do. Okay, so this is the how I prepare my patient for phaco. It's a bit different from what you saw this morning, but you know, on a typical day, a typical case, I do a 360 periotomy. I hook my muscles. And you know, I just have, you know, time doesn't really matter. So I have my whole time. You know, it's a long day, and we just this is my startup case. I mark my sclera, and I have this passion of peeling up the sclera. I have, you know, a great passion for. I just peel 90% of the sclera on like 1/3 of the eye wall volume. So I'm proceeding with making a huge flap, like 90% thickness over that extended area of the group. And just keep checking every now and then marking again. And then I'll start doing my cataract now. It's a difficult, complicated cataract. Patient was a bit uveitic, maybe, I don't know. So I just watch here, you know, you should be pressing on the upper lip of the wound, not on the lower lip of the wound. And you continue with your access. Very shallow anterior chamber. We use really dispersive here, white cataract. I do a quick chop technique, so, you know, narrow pupil, posterior synechia, quick chop. This is level 3 difficulties. with a sclera dissected at like 1/3 of the group. We just keep going, trying to avoid eating up the iris, and then I'm done with my phaco. What's this? Okay, so I will put my lens, and then do something else and close. And I will repair even the iris here. You know, the iris was partly cut after doing something, and I'm just closing with the IOL in place. So what did you guys miss? You missed the fun part of the surgery for me, which is like taking the tumor out of the eye. This was the big melanoma. Iridoceliochoroidal melanoma that was really inducing the cataract for a bit of a long time. You can see this is the ciliary body, the pars plicata of the ciliary body. It will show up here. And we carefully dissect the pigment epithelium, and we push away the retina as the tumor comes out. So this is the melanoma. And this is how we kind of peel it away from the retina and the ciliary epithelium to be able to perform the cataract. So this is a very typical day for me. We do this maybe twice a month or something like that, and we proceed in a phaco that lasts for an hour and a half to 2 hours to have another formed globe. You can see the ciliary epithelium in continuum with the retina here, the ciliary vessels beautifully going onto the retina in a very unique way. And this is how big the tumor is. You know, it's almost like 2 centimeters with the thickness inside the eye. And we removed it in total. So this is a total resection of the mass. So I'm the fastest. My cataract takes about 2 hours to go. It's important to have a free eye. Before proceeding with putting the speculum, remember that trachoma is endemic in our part of the world. You see here, there is no inferior fornix in such a lady that is old enough to have shortening of the inferior fornix due to trachoma, due to cicatrizing disease. So what you should do here is test the mobility of the globe. This is very important. Test mobility of the globe and release. Don't go beyond 8 millimeters to release the inferior fornix. Just be closer to the limbus, because why? At 8 millimeters from the limbus, the septum is there, and behind the septum is the white to pink junction, is the orbital fat, where you wouldn't be daring opening the orbital fat, as you will induce damage to an orbital. You'll fix the globe. And my preferred technique here is the quick chop. As I go, I make a little groove, and as you see, my hand is ready here, and I chop without even creating a groove. You know, the groove here was to induce vacuum, and another chop. And then we have one part of the nucleus. We have 2 parts of the nucleus, 3 parts, or whatever you want. The more parts, the easier. As you just take out one part, the other becomes so easy and beautifully, beautiful red reflex without needing to even induce IA. You see, it's important to have a free globe to be able to maneuver the globe. Sometimes, if our wound is a bit posterior, we end up by having a big balloon. You see here, I tend to be like posterior clear corneal incision, you know. So I'd like to see some bleeding. Sometimes when you proceed with your surgery, as you go making every technique that was shown here, you know, the rhexis, the hydrodissection, you'll start noticing that the, ooh la la. Okay. So whenever you're having like a posterior corneal incision, and the conjunctiva gets ballooned, one trick to do is to do a 6 o'clock periotomy. To deflate the conjunctiva, which I think is important in maneuvering the ballooning, which sometimes can be very, very annoying to the surgeon and to the procedure as well. لا خلاص هبتدي تشتغل تاني اهو، انا راجع اهو، حطني on as well. So, okay. So you'll start by seeing the conjunctiva being ballooned. As you can see here, do your 6 o'clock periotomy and proceed with the surgery so that the conjunctiva will deflate and the procedure will go without the conjunctiva being on your way, hindering the performance or the continuation of the procedure. Okay, I have two more things to show you, and I will quit. You know, this 3-month-old boy came in and he was scheduled somewhere else for a surgery, cataract surgery, the second day. You know, and I said, okay, maybe it's not a cataract. You know, you can see here the was diagnosed as anterior polar cataract, but the anterior polar cataract doesn't really go beyond the iris. So before planning to perform any access, I decided to have a deeper look at the membrane here. And as you can see, it peels off easy. And you can see the red reflex. So using the vitreoretinal instruments is sometimes very, very useful in our anterior segment surgeries. And it really peeled off completely. The patient didn't have any cataract, no anterior capsule or posterior capsule, nothing. And the beautiful red reflex. We saved the eye of this patient. You know, if this patient was it turned to be aphakic, unilateral aphakia in kids is extremely difficult to treat. I thought about maybe doing some pupilloplasty to have a wider opening of the pupil, and that's it. You can see the beautiful red reflex, you know, and the guy, you know, is grown up enjoying vision in both eyes. Sometimes if you go for access, you know, this is a uveitic slash diabetic patient who's been neglectful for a long time, and the planned procedure was a phacoevitrectomy. So you see these wrinkles, they're not supposed to happen. This is a very sharp cystotome that was really recently prepared. And you can try to do a access, the central opening. It doesn't really open, you know. If I think broader, there is a transparent inflammatory membrane that really extended on top over the iris. You can see that. You see, this is the membrane. So this is not a simple capsule that was present there. There is a membrane that you can peel off the anterior lens capsule and the anterior lens surface. You can see that it's extending in those patients with uveitis and chronic uncontrolled diabetes with a lost blood ocular barrier. And then now this is the capsule. It's easy to pinch it, easy to continue your access within, and you know, and proceed with your surgery as you wish. You know, you can proceed with surgery in opaque cornea. You know, you don't have to always to do a triple procedure, but you can proceed with the surgery using several tips and tricks to enhance the visualization of the anterior capsule and showing off your procedures in a nicer way. Those tips can be the staining of the capsule, as was shown before, and also you know, using the oblique illumination of the vitreoretinal vitreoretinal machine. It's very useful if you use it as well, and also the oblique illumination of the microscope sometimes that can be really helpful in those procedures. So these were the difficult cases. I'd like to hand the microphone now to Dr. Hisham Gharib, as he will show us more difficult cases and complications, and we'll get back to you later on.
Thank you. More difficult cases, Dr. Ihab. Okay. Okay, I will show you some of difficult cases that may face us. First of all, the anesthesia. When we are going to prepare for surgery and we are thinking that our friend, the anesthetologist, have given good anesthesia for the patient, and you enters and seeing that the eye is just moving around and the patient is much in pain. So the subtenon anesthesia augmentation may be the key. Here you should use, my technique in that is to use the normal IV cannula, pinch the conjunctiva and the tenon capsule with it, 7 or 8 millimeters in the lower temporal quadrant. Just put the needle bypassing the equator, remove the plunger, and inject your 2 millimeters of lidocaine. This will be very enough for the eye to be akinetic and without pain. Simple maneuver that can be done in few seconds or in a minute and makes your surgery is much more easy. The patient now is akinetic and with no pains as I pinch out the eye. One of the steps that Dr. Ahmed Hamdi have told us is the hydrodissection and delineation. It has been for a long period that this step is very frightening for me because I had from it some of complications. So I changed my technique to central hydrodissection and delineation, as I will show it to you. The normal hydrodissection is to introduce the hydrodissection cannula beneath the capsule and injecting fluid so to strip the cortex away from the capsule. As we saw, the fluid is doing the hydrodissection and then the delineation. But if capsular block occurs, posterior capsular rupture may happen, as in this case, when vigorous hydrodissection ended with posterior capsular rupture and the lens tended to go down. So I changed the technique, and what about pushing the fluid in the central part of the lens, not beneath the capsule? Pushing the fluid, just with the gush of the fluid, it will enter by itself under the capsule, stripping off the cortex from it, and also tilting the cannula to be central part of the lens and doing the delineation. As we see here, the cannula is in the center of the lens and the fluid wave have passed all over the lens in 360 degrees. Also, the hydrodissection, the hydrodelineation ring with the golden ring has occurred. In many cases, it's a reproducible technique and can be done. In wide cataracts and dense cataracts, when the posterior capsule is not seen and the hydrodissection is relatively contraindicated, so I can use the central hydro to save the day. Also in this high myop patient, as we see from the white red reflex of the chorioretinal atrophy, it's done. With the posterior polar cataracts, when we shouldn't do hydrodissection, only do hydrodelineation, also central hydro can save the day without opening of the posterior capsule. What about if I had an extension of the rexes? It's saved but still extended. It's not very safe to do normal hydration. So I used this technique of central hydro to do the stripping of the capsule against no resistance. So not opening the posterior capsule. Sometimes the delineation starts before the dissection, and if it doesn't complete, you can go with the original technique, subcapsular, and do your hydration. Next is the posterior polar cataract. We all know that 20% at least there is congenital opening of the posterior capsule together with this congenital anomaly of the lens. So we shouldn't do hydrodissection, as I told you a few minutes ago. The posterior polar cataract may be associated with soft nucleus, as in the left side, or harder nucleus, nucleus 3, on the right side. Both will be managed in the same principles. Do not do hydrodissection, only hydrodelineation to delineate the nucleus, then conquer the nucleus with your usual technique on the left side as debulking, as it is soft nucleus, while on the right side it was by quick chop technique, quick chopping the nucleus into small parts and eating it as piecemeal. After entry, I have completed eating the nucleus. Now it's time for the epinucleus. Always visco express the epinucleus together with the posterior polar part, using dispersive viscoelastic to express the epinucleus shell. And also, if there was a posterior capsular break, it will help to sequestrate the anterior vitreous and avoid vitreous prolapse into the anterior chamber. After you have done this, together between the epinucleus shell and the posterior polar plaque, it will come with ease without posterior capsular break, and you can inject your lens safely. Dealing with dense cataracts and white cataracts is such challenging. And this is my technique is while dealing with these types of cataracts. I want to share with you some tips. All of us are afraid from the Argentinian flag sign with the capsule is stained by blue stain and the cataract behind is white and extended, that may lead eventually into posterior capsular break and may lead to dropping of the nucleus. We all don't want that. So my safe surgery starts by doing the good incisions, very lamellar incisions, so that no viscoelastic comes out throughout the surgery. After staining the capsule, I inject viscoelastic. It's better to use cohesive viscoelastic, viscoadaptive, highly viscous, or soft shell technique. After that, starting the rexus by a small snip, removing the emulsified cortex from underneath the capsule to decrease the intracapsular pressure, then continuing the rexus as a small rexus in a spiral manner, starting by small rexus and widening it part by part in a spiral manner to be as large as 5.5 to 6 millimeters. Be sure at each stage to have good pressure inside the anterior chamber. Nucleus fragmentation, all fragmentation techniques that Dr. Ihab and Dr. Muhammad Ibrahim have told us about can be done. Here, horizontal quick chop can be used. Even horizontal chopping can be done without a specified chopper by Sinsky hook. Vertical quick chop can be done using a sharp instrument. And if we don't have this instrument available for vertically chopping the nucleus, just bend a 27 gauge needle, insulin syringe needle, to use it as a vertical chopping, as in here. This is the needle of the insulin. Also, posterior chopping can be done by any blunt instrument from back surface of the nucleus. If you are stop chopper, again do stop and chop. If you are to do DNC, do your divide and conquer. Any and each technique of the nucleus emulsification cracking and emulsification can be applied here. It's better, as Dr. Ihab said, to do the quick chop techniques to decrease the dispersed energy, dissipated energy. It's better to use the cold phaco, burst, pulse, or hyperpulse modes to decrease the effective phaco time and decrease the dissipated energy inside the eye and decrease the postoperative corneal edema. After that, your case have been finished and continue with irrigation, aspiration, and IOL implantation. What about shallow ACs? Always remember to see for every detail inside your pyometry. Here, the anterior chamber depth is below 3 millimeters. I have a nomogram that if any patient have an anterior chamber depth from the internal side below 2.8 millimeters, I give 2 tablets of Diamox, Cinemax before surgery by 1 hour. If it's less than 2.5 millimeters, I will give mannitol injection or infusion half an hour before surgery. But if it is below 2 millimeters, I will have something else to do. This patient came with phacomorphic glaucoma. Intraocular pressure was 35 and anterior chamber depth was 1.2 millimeters only. I have 1 millimeter to go doing phaco. It's impossible for me to do that, so I had to do a sclerotomy 3.5 millimeters away from the limbus, going with the 20 gauge vitrector with high cut moderate vacuum to cut the anterior part of the anterior and curve vitrectomy. After that, I had to inflate the anterior chamber with a pre-done paracentesis. Remember, before doing vitrectomy, do the paracentesis as the intraocular pressure will be low. After that, closure of the sclerotomy was done, and I had the surgery in fast mode so that we see that the whole surgery came in with ease and safely. It's a normal phaco since that, because we now have a good wide anterior chamber rather than 1 millimeter to work in. We finished the surgery safely because of widening the anterior chamber. These are some of my difficult cases, much easier than Dr. Ihab sees in everyday practice, but I wanted to share them with you. No complications? Referring back to Dr. Ihab, inshallah.
Thank you very much, Dr. Hisham. The ease comes from the simplicity in handling things, and I think Dr. Hisham is one of the leaders and pioneers in this line, and he has really a very wide experience in his techniques. So its simplicity comes with experience. It doesn't come haphazardly. It just comes with experience. If you just, I'll go for a few minutes over some of the complications, and then we will finish up by showing more cases that really can be encountered. So when you have an opaque cornea, it doesn't mean always that you have to have a triple procedure. So the levels of difficulties here, how thin the cornea is, how strong would the eye hold a 90 cc's bottle or 120 cc bottle? How good are you going to see the details? Staining here is primordial. And as you can see, we inject the dye. We go with our stepped incision. We inject our visco. And then, my preferred way is to go through the paracentesis, actually, and proceed with the phaco. As you can see, there is no leakage from the main wound. If you do your paracentesis slightly obliquely, not at the 9 o'clock position, you can proceed whether clockwise or anti-clockwise. You can see the beautiful contrast of the axis that you would continue. The most important step in phacoemulsification is to do a good axis. This is of primordial importance to be able to finish. And if the axis breaks in the direction of your phaco tip, convert to extracapsular cataract extraction. This will be much safer. So now we do the regular steps, and things go nice and easy in every and each one of the steps until we implant our IOL, and we're good. IOL complications come with the loss of the capsule, whether the anterior capsule or the posterior capsule, and the capture, whether anterior or posterior capture, is important. The point is how to proceed with capture. So I just, so the one of the techniques is to do a reverse optic capture, or sometimes this is a very misplaced IOL, is to go posterior. For anterior segment surgeon, it's difficult. You see, this is the posterior capsule that was ruptured and the IOL was displaced. So I thought how to have a continuous rhexis in the posterior capsule. I inserted 23 gauge trocar, and then I went with the forceps, the posterior segment forceps, and I created another posterior rhexis to have an IOL optic capture. You see that the rhexis comes beautiful, so to be aligned with the anterior rhexis, so that I can, replace and capture the optic in the posterior and anterior capsule as well, after regulating the size of the posterior capsule. So think about using your posterior segment skills in the anterior segment surgery. You see here, the IOL is beautifully entrapped into the captured anterior and posterior capsule all together. So this is a very nice trick to perform. Sometimes it's not one of those days, في sound ممكن? So I was trying to do a phacoevitrectomy, and this was a very high-notch reported person. The hydrophilic, this was a hydrophilic IOL, got captured within the injector. I really didn't want to cut it off and change it, So I decided to cut the injector, using my left hand. And this is one more step. Be ambidextrous. Use your both hands is really important. So I kind of released, the optic, the trailing optic, with difficulty, في مزيكا؟ مفيش ساوند ها؟ شغالة؟ سامعينها؟ So this was done successfully. The IL went in the bag. Patient had a posterior segment procedure to be performed at the same time, so we have the trocars. And while being busy adjusting the IOL, look in here, methyl comes with bubbles, and oops, we have a suprachoroidal effusion, that? And you can really hear your heart beating, And you just have to remove your effusion, place it somewhere else, try to drain from the suprachoroidal space, replace another, one more time your infusion, and you have to have really good assistance here to ease up the stress, a good heart, the worst thing that can happen to a patient if the surgeon dies, the next worst thing is if the patient dies, so we don't want anybody to die, so we really have to proceed safely with the procedures. Every complications happen in this case: suprachoroidal effusion, choroidal hemorrhage, and then we have to drain the suprachoroidal effusion, and we ended up the procedure nicely, injected silicone, and we are winners at the same time. So this is the another nice case that went off. In closing the case, remove the viscoelastic, check for residual vitreous stents, and be having low threshold on closure of the wound. Don't be afraid of that. I will finish the presentation with a technique that I use, the double rectangular scleral mesh in aphakic when we don't have any support. So this is a very nice technique where you use your 10-0 Prolene suture transsclerally, 1.5 millimeter from the limbus, pass the suture along, creating a rectangle, transsclerally, transocular. The first rectangle is created, then we go for the second rectangle. And then if you have a dislocated IOL, you can easily put it back in position under a very close system using the same IOL. This is a 3-piece IOL where you can really position and capture the optic here, give support to the optic and capture the optic to be able to have a very nicely and beautifully placed IOL. Proceed with your posterior segment surgery. This technique has been published, and I'd like you to look more and more into the technique as it gives long-term stability of the IOL. This is the double rectangular mesh. The optic is tethered within, and it can be used for, it has so many other indications. I'm finishing up here and proceeding the microphone to my colleague, Dr. Mohammed Ibrahim, with his difficult and challenging cases at the same time.
Okay, thank you, Dr. Ihab. Of course, Dr. Ihab is having myriads of very, very tough cases. May God be with him. Actually, my videos will be much simpler than this. I usually enjoy to prevent more than to cure. I usually teach my residents, observe signs and do not wait for complications. You should be apprehensive enough to tackle complications even before they happen. I'll show you some few tips and tricks and videos is showing very minimal signs. If you tackled early and treated safely, you will proceed effectively without complications, inshallah. Okay, sorry for technical issue again. And this is a case which we started with a narrow pupil. This narrow pupil can be easily tackled with just intracameral adrenaline. Yes, please use the adrenaline you have, whether it's preservative-free or with preservative. Just dilute it 1 to 10 cc of irrigating solution with 1 ampoule of adrenaline. It just acts marvelously. Usually you observe the dilating pupil on table. Then you can continue safely. As you see, the case was averagely dilated and I can do my rexes and continue my job. This is case number 1. Case number 2 was an average sized pupil. Yes, this can be done easily. I just want to stress about the role of viscoelastics. As mentioned by Dr. Ihab and Dr. Abiola, the role of viscoelastics is very important. I prefer viscoat, a highly dispersive viscoelastic with a high molecular weight. It's much more effective than HPMC. As you see, I usually inject it intracamerally. Of course, Dr. Arshinov described the Arshinov shell with viscoat and underlying Helan or cohesive viscoelastic. I use pure viscoat. It just gives me very good dilatation, very good stability of the anterior chamber, and the pupil remains as it is, fixed in place. And the case is straightforward again. Okay, let's go for more tougher cases. This is a case with hard cataract and relatively narrow pupil. I used intracameral adrenaline and it didn't work for me enough. So I started staining the anterior capsule using again viscoat and then using another technique to dilate this pupil. This is called manual iris stretch. You can just use 2 instruments to push the iris in different directions so that the pupil gets wide enough so that you can continue the case. Now, if my pupil can allow me to do rexes, usually it stays as it is. If it's not floppy iris, I'll just show you floppy iris syndrome. Then I can continue like this. It's a tough case, hard one, but chopping goes well, and the case was finished successfully. Now this is another issue. This is intraoperative floppy iris syndrome. Floppy iris syndrome, as you saw, this is iris billowing. The iris is playing everywhere. And now it's trying to prolapse through the paracentesis. Just when you observe this, stop, close your irrigation, close continuous irrigation, press with your hand on the paracentesis until this iris that's stuck inside is released. When it is released, open again continuous irrigation, instruct your nurse to put adrenaline on the irrigating solution if not already put, and try to continue. If troubles continue, you should go for more aggressive management. I'll just show you. Now intracameral adrenaline was more than enough for me. I can continue chopping. Its iris stayed now, no more prolapse. So I proceeded safely. This is a case with iridus cases. I don't know if it's evident or not. The inferior iris is completely splitted anterior and posterior lamella with very frayed anterior lamella. So I use iris hooks. A few tips for iris hooks. Fashion your incisions very correctly. Use very short tunnel. Do not use a long tunnel for the incision. And do not enter with your knife or MVR completely. Just a puncture, only to allow the iris hook in place and avoid a major leak. Fix the 4 ones and then get the iris coat and continue. Now I can continue safely. My rhexis was done. Phacoemulsification can be okay. And remove your iris hooks. This is a case with iris atrophy and very constricted pupil. Stain intracameral adrenaline, nothing works. I used again iris hooks, and it went fine. Now we come again, but with other problems of the iris. This is a case with previous acute attacks of glaucoma. As you see, there is a PI here, and there is anterior synechia. I have some strategies for the synechia. If this synechia is close enough that you cannot continue your rhexis, then you have to release it first. In this case, I just used a highly dispersive viscoelastic. I injected it into this synechia, and this is my beloved viscoat. And as you see now, I'm just injecting. I didn't even touch it. And it's released. Now I can continue without problems. But what if it's a tougher case, harder one, with synechia that does not permit me to do my rhexis? Then I have to release it first, even before injecting the viscoelastic, in order to inject stain. So under saline or irrigating solution, I start to release my synechia, and then do my stain and inject the viscoelastic. If I can continue like this, okay, well and good. If I cannot, then you have to do iris hooks or some more steps. Here I did manual stretch. You saw it before, and it was enough. Okay, and this is my before the last case. This is a uveitic patient with a very narrow pupil. Actually, uveitis usually have a membrane on the pupil. You have to dissect it first. Then you can use iris hooks in the same technique. My last case is a case with hypermature cataract, calcified anterior capsule. Be very cautious when doing your rhexis here. Your rhexis usually get caught in the area of calcification and it resists to move. As you see, the calcified capsule comes in one piece, so the rhexis can run away. Do not try to pull on it. This is my tip. If I continued pulling right now, the rhexis is gone. I tried some more. Okay, it's not coming. So I shifted and cut it. When cutting through the calcification, do not be afraid. It will not run. And now it's complete, and phaco went straight forward. I think this is enough for me, and I'll leave the microphone to Dr. Hisham.
Thank you very much, Dr. Muhammad Ibrahim. Beautiful collection of cases, and we've been through every step. Dr. Abiola was mentioning about the the iris hooks. There are several types of iris hooks. These are the simple iris hooks that we used. Other types would include the capsule iris hooks that would hold the capsule as well if you have a partial subluxation of the lens, and will allow you to continue with phacoemulsification as well. For iridocyclitic patients, think about an anterior segment membrane, as I showed you, or dense calcific anterior capsule, which really has to be dealt with a scissor. Also, if the patient had an old cataract done before, uveitic patients tend to have also sommering ring and entrapped cortical segment in the periphery that would push an IOL away and would make things more difficult. You can reopen the capsule and try to remove the peripheral junk that is there as well. Dr. Hisham will briefly discuss with us a few of the complications in the next few minutes, and we'll keep like 5 minutes for discussion. If you wish, send us all your questions, and all this will be online recorded for whomever would like to join in or see it later on. Dr. Hisham.
Really, the main important complication that may encounters us is the posterior capsular tear. So if you have a posterior capsular tear, you should manage it well. Many things will be important to bear in mind, like the state of the posterior capsule and anterior capsule. Is there vitreous prolapse? Is there still nucleus fragments or cortical remnants, and age of the patient? First things come first. First, don't panic. Hold and balance the anterior chamber pressure. Manage the vitreous prolapse and the big fragments, then choose the IOL to implant or defer the implantation. If you have a posterior capsular rent, there are different IOL implantation techniques that you may use. First, still you may make in-bag implantation. Here I had a circular posterior capsular tear, but it was managed with posterior capsular rexes, and again a single piece hydrophilic IOL, acrylic IOL, can be implanted safely inside the bag. Another option will be a sulcus implantation. Here, while I didn't have enough posterior capsular support, but a good rexus was present, I opened the corneal incision and put a single piece rigid IOL in the sulcus. Remember to subtract part of the diopteric power of the lens according to the power measured, as we talked about this last time. Also, sulcus IOL can be done using 3-piece IOL, multiple pieces IOLs. As in here, when I had a linear crack in the posterior capsule, but was not enough to put in bag implantation, so I used a multiple piece IOL to implant. First, inject it into the anterior chamber, then put the haptics one by one into the sulcus where you want. As it's a linear posterior capsular break, the haptics should be put in the opposite direction of the break. So I had to put it first in the anterior chamber, rotate the lens in position, in the final position, and put the haptics one by one. Inject viscoelastics, copious viscoelastics above and below the lens. Then rotating it in position, putting the second haptic inside the eye. As I told you, it was a linear vertical tear, and the haptics should be put perpendicular on that tear. If it is put in in line with the first tear, the IOL may go down. The third part is the anterior chamber IOL. It may be an option to put when you don't have both posterior or anterior capsular support. I have done a PI, always do a surgical peripheral iodectomy if you are to put anterior chamber IOL. Another option is the retropupillary precise iris claw lens. Here there is no capsular support in this patient, had traumatic cataract and total dislocation of the whole bag. So using this elegant lens to be put inside the eye, just claw the iris, just entangle the iris into the claws behind, from behind. The IOL is very stable and can be put through a small incision without significant steel enter. Okay. طيب. Okay. Here we will see a posterior capsular rupture. If you ever had a posterior capsular rupture, as I was doing my phaco here and nearly completed the phaco, but now, whoops, I had the capsular tear through during the IA. It's still rented, but the first thing that I told you, don't panic, pressurize the anterior chamber, do not invite vitreous to come to the anterior chamber, pressurize with any viscoelastic that you have, change the rent toward circular or a curvilinear opening by posterior capsular rexes and put then the IOL in back. In here I had, during the cataract surgery, and nearly I have finished the case, but whoops, there is a plow. There is a plow that we will see here, in here, and there is a posterior capsular tear because of increased positive pressure. I didn't realize until I was injecting fluid, but there's no posterior capsule to put the IOL on, so I changed my mind to put a single piece IOL in sulcus. As a routine phaco case, a small and soft cataract, and as I was doing the hydrodissection, a flow of the posterior capsule occurred and the lens tended to sag and go down. It was because of using a wide pore cannula for the hydrodissection. And I want you to see something, the pupil slap sign, when the pupil slapped me for not treating it with respect. So anterior assisted levitation, I entered with an MVR at 6 o'clock to just not letting the nucleus to go inside the eye, and managed with another instrument to regain the nucleus towards the anterior chamber. Now with the nucleus in the anterior chamber, you can widening your wound, converting the wound to extracapsular cataract extraction, and continue and manage the lens. In the last video, I want to show you this case. Very old lady came, and as I was doing the rexes and started phaco, the nucleus, as you see, is shivering. This is indicating total capsular dislocation. So I changed my mind and gone for convert to extra cap. I tried to remove the nucleus into the anterior chamber, both by using a sharp instrument to pop the nucleus up into the anterior chamber, and visco expression all failed, but what saved me is the posterior assisted levitation 3 millimeters away from the limbus, entering with a sharp instrument and supported the lens before it goes down, and the lens was saved. Anterior chamber IOL was put, and the patient was saved. Thank you.
Thank you very much. Very beautiful, difficult case combination. We have a question, a remark from Dr. Abiola that very short tunnels are important during iris hooks, and this has been emphasized by Dr. Muhammad Ibrahim. If we have a subluxated lens for 6 clock hours, it depends on how comfortable you are. If you have the capsule iris hooks, I mean, those that can go and impale the anterior rexus and hold the capsule. So I will proceed with phaco, very cautious phaco, and put a Sione ring, and then a capsular tension ring, and then put my IOL. If it's safer to go extracapsular, I would do extracapsular, or even intracapsular, we proceed with intracapsular. If Dr. Oilai would have, and Dr. Ogundipe would like to have concluding remarks, we're just running out of time.
Yeah, it's been a very beautiful.
Okay. Dr. Ogundipe is online here? Yes.
Yes, it's been a very beautiful session with many tips, many polls, and things to run away from. I don't have much to say than that we've had a wonderful session. The one thing that may cause posterior capsular rupture when you are doing your hydro dissection, apart from when you have a posterior polar cataracts that you are not mindful of and you went ahead with hydro dissection, it's been advised that if you use, a viscous OVD, that you should aspirate first before you do your hydro, because the weight can make the fluid not to come out easily, and there's a tendency for you to want to increase, thinking that you need to inject more so that you can have your dissection, and in the process, it just goes down and you may have a posterior rupture. So it's always better to clear your anterior chamber of visco before you do your hydro, if it's a straightforward, simple case. So thank you very much. I'd like to thank all the speakers.
We don't have really a good, ample time. I'd like to thank our team, Dr. Hisham Gharib, Dr. Muhammad Ibrahim, and Dr. Ahmed, and also the EPICO team for allowing us to share with you this little experience, and looking forward for more educational material and exchange experience with you guys. More to come. Looking always forward to come to the OSN whenever time and God would allow, Dr. Ogundipe and Dr. Oilai. And it's always a pleasure to see you guys. And Assalamu alaikum, ma salama, goodbye from Egypt, and see you soon, inshallah.
Thank you very much. Bye.